Our last speaker on this panel is well known to many of us, not a new faculty member. Paul Wise is the Richard Berman Professor in Child Health and Society, which is probably the most apt title for the Health Ecosystem panel. And he's going to talk about the future of child health in an aging America.
Thanks, Tom. Thanks so much. In the May 1863, at the height of the Civil War, the Battle of Vicksburg, Orion P. Howe exhibited remarkable bravery on the battlefield. Already seriously wounded and running through what was described as a hellstorm of canister and musket balls, Howe delivered critically needed ammunition to the soldiers on the front line. For his bravery, Howe was awarded the Congressional Medal of Honor. What's remarkable about this story, and why I present it today at a Childx conference, is the fact that Orion P. Howe was 14 years old. Now, I mention this at the beginning of my talk because it is a perfect illustration of how dynamic our vision of childhood, the notion of childhood, is in the United States, of how dramatically it changes over time. And my suggestion is that if we're going to talk about many of the issues, the challenges that have been brought up in this conference, but particularly if we're going to talk about a responsive and effective child health policy in this country, that we're going to have to recognize the dynamic quality of our vision of childhood and address it directly. Now, there used to be something called child health policy in the United States. However, over my professional career, we've seen basically child health policy evaporate. And what has happened, and the reason for this, is basically because health policy has turned into cost containment policy. And when you begin to talk about cost containment policy, it spells trouble for children and child health. Here's why. This is expenditures for a variety of different programs. Medicare. You can see that it's a little more than $500 billion, 2013. This is Medicare plus Part D, the prescription benefit program for the elderly. This is Medicaid, the program for the poor. This is the portion of Medicaid that's spent on children. And I've also included in this graph an arena of child health care that is famous for being having exorbitant healthcare costs, which is taking care of preemie babies in neonatal intensive care units. And when you add it all up across the country, it's that. Can you see it? Okay. And basically the message here is that you could add up all the care for all the kids in ICUs from all different conditions, and it's basically a rounding error for Medicare. It's what in Washington is called budget dust. And when you start talking about cost containment, kids' issues basically fall off the radar screen. Why? Because they don't cost anything. That the bulk of the activity around cost containment and therefore in health policy these days is for the adults and particularly the elderly. And what happens to child health policy when you have a situation that looks like this is that child health policy becomes adult health policy applied to children. Now, what's wrong with that? What's the problem? Well, we know that there are, in fact, distinctive elements of child health that are critically important, that distinguish it from adult health. One is we know that the content of pediatric care, of child health care, is different than that for adults. And we know that by just looking at the face of an internist being confronted with having to intubate a 24-week-old preemie. It looks something like this. Okay, so we know that the content is different. But there are also differences in the epidemiology and therefore the architecture of child health services that are also different for children than for adults. Now, what could we be talking about here? If I had a heart attack right here, most community hospitals would be very good at taking care of me. Why? Because they see a lot of guys my age with heart attacks, that the volume is pretty high. But when was the last time that that community hospital saw a 7-year-old with sickle cell disease and acute chest syndrome? Once every 5 years? that serious illness in kids is relatively rare, and in adults it's relatively common. And for pediatrics and child health policy, this has meant over the last 40 years that we have had to institute systems of care that concentrate children with serious health problems into specially designated centers through regionalized systems of referral, into facilities that are able to invest in the expertise, equipment, personnel to provide high quality care for kids with relatively rare conditions. Okay. But now in a financing environment where you're seeing all kinds of new kinds of contracting systems, systems like accountable care organizations, when you ask, where is the sophisticated care for kids with special health care needs in your health plan, in this new ACO, which has almost always been developed for adults, because that's where the money is. What you hear, and I actually heard this, is show me the study that an adult pulmonologist cannot take care of a 10-year-old with cystic fibrosis. Okay. There is a profound disrespect for the expertise and requirements of regionalized services for child health in the current health policy world. Now, I don't want to belabor this point, but another area of distinction is in fact the weak political voice of people who care for children in the United States at this time. Now, when I say this, I make this observation, people say, well, yeah, it's because kids don't vote. But the real question is, why in God's name should they have to? What has changed in American society that would even raise this question in the first place? Now, the last thing I want to do is pit the needs of kids against those of the elderly. Yes, I am a policy analyst for kids my whole career and have tried to advocate for responsive child health policy. However, I also know something about the needs of the elderly. Both my parents have Alzheimer's. My mom passed away last summer after a 10-year decline, and my father is in the midst of a very similar decline as we speak. I know something about the needs of the elderly. But what is striking about what I've learned through this experience is that the needs of children and the needs of the elderly have far more in common than they do in conflict. And we need to be cautious about how we reframe and how we create a vision of childhood that is disrespectful of the requirements of the needs of the elderly. Now, we have been through similar points in our history where we have had to revision notions of childhood, to change our notions of childhood. And we can learn from both the struggles and the successes that took place at these different periods of time where the vision of childhood was changing rapidly and our policies had to change in response. Okay. Now, it makes me consider, okay, what's my prescription? Okay, and I can't give you a detailed prescription because I've used the first 9 minutes of my 10-minute talk on making the case that things have to change, that the status quo is inadequate. But what I can say are three things. One is that we have to create a more unified public voice in the policy sphere. Two, we will have to use this unified voice to craft a new vision of childhood. And three, that this new vision of childhood will need to relate and respond to the dramatic, unprecedented demographic shifts that are taking place in our country today. It often reminds me of an I.F. Stone image of a group of researchers documenting the movements of a troupe of dancers from behind a plate glass window. They can record with great fidelity every leap, every jump, every turn, but they never hear the music. It's critical that we begin to hear the music, that we understand and listen to the fugue of interaction between technical innovation, social stratification, and profound demographic change. We need to recognize that the really breathtaking discoveries that have been discussed at this conference, if they ever are going to make a difference in the lives of real children across this country, that they will have to confront the exercise of power that they will, at some level, have to confront the clash between democracy and demography, something that we have never witnessed before in the history of our country. My suggestion is that our current science and our current advocacy will not be able to address this challenge. It will not be able to address the failed sense of why childhood is essential in this country, nor will it be able to address the failed sense of the very purpose of childhood in a rapidly aging America. So thank you.